tuned in for today. We're having some technical problems, but if you can hear the audio, you got the video yesterday in the email that came from the Allergy office. So you ought to be able to follow along. Jonathan, our speaker, will call out the slides as he changes them. It's almost identical to the presentation yesterday. So I'm told you can hear the audio, follow along on the video that you received yesterday. And I think we best go ahead because Jonathan's got a full agenda on reviewing all the biologics for asthma. Thanks for coming up here from UCLA. Sorry, we're technically inept, but let's go for it.
My own level of expertise isn't so great. So thank you for coming so early in the morning. And it's nice to be back in this room since the pandemic. I think the last time I was here was about 4 or 5 years ago. So we're going to be talking about where we're at with biologics, where we may be going, and how do we fit all this together, for optimizing care for patients. My disclosures. What we're going to talk about is a little bit about where directions are going in terms of understanding pathogenesis and formulating targets that we can appropriately treat with some of the new medications. And then talk specifically about mechanisms of action and some of the more recent data drawn from both pivotal trials as well as some post hoc analyses, and then go through a couple of cases that I think might be interesting to kind of put all this together. So when we talk about asthma pathogenesis and phenotypes, what we're really going to do is try to get a sort of a fleshed out view of where things stand in 2024. And we know through a lot of gene network analyses regarding the pathogenesis of asthma that there are literally hundreds of candidate genes. And some of the more important ones that pop out consistently in many of the studies that have been done are the genes for IL-5 and 13, the IL-4 receptor and TSLP, with all of these being upregulated in a sort of a constitutive manner, waiting for the right trigger, so to speak, whether it be allergen exposure, where some of these genes interact with the environment, or some other event like a viral infection later in life. And we also know that some of the important junctional proteins from the epithelium, particularly filaggrin, which is a good example that stands out for patients who have atopic dermatitis and who have asthma, that may be an epithelial abnormality that actually predisposes them to the development of asthma. What's interesting through many of the studies, the susceptibility loci, whether you're looking at early leading to food allergy, rhinitis, and then asthma. And the atopic march doesn't always occur in that order, but that's kind of the way we do see it typically occurring. And when you look at eosinophilic non-allergic, again, a type 2 disease with lots of eosinophils, but a late onset, they do have atopy, they do have elevated IgE, but it doesn't seem to matter very much. And typically these patients often develop chronic sinusitis with polyposis, and AERD being a subset of that. Those patients, about half are allergic, half are not allergic. But again, like its greater category being the eosinophilic non-allergic, late onset, the atopy doesn't seem to matter too much when you treat these people with immunotherapy at least, and they have polyp disease. About 70% of patients are thought to have type 2 disease. This is by doing NIOXs and looking at blood eosinophil or sputum eosinophil counts. About 30% of patients are considered to have probable non-type 2. But it turns out some very recent data is emerging that if you take many of these people who are actually assessed while on inhaled steroids and judiciously taper them off of their controller, a lot of them end up having eosinophil counts above 150, excuse me, and exhaled nitric oxide levels above 25. So more recent estimates are that real bona fide low type 2 or non-type 2 asthma may be as small a group as 5 to 10% of asthmatics. And many of those patients, particularly those with neutrophilic, may have a concomitant infection. And you can have neutrophilic, as I mentioned. You can also have non-inflammatory, where there's bronchospasm. There's the physiology of asthma, but without the inflammatory milieu that we're used to seeing. And frequently these people are in a metabolic situation. They're diabetic, they're obese, hypertensive, and the big factor in those patients seems to be IL-6. So we'll be seeing a lot more about IL-6 in the future, I think. The biomarkers we're all familiar with. If we look at the left, which is really the cytokine target, and then look at how does that correspond to a clinical biomarker, IL-5 is well represented by blood eosinophils. And basically based upon clinical trial data, we've defined it as 150 cells or higher being a eosinophilic patient. It's interesting because some basic work done by John Fahy's lab up at UCSF actually took bronchoscopic samples and found where you really see a message or mRNA in the lung for IL-13 or IL-5 usually is an eosinophil count around 200 to 220. So that 150 is really a bare bones estimate of what type 2 probably is. IL-5 and 13 cooperating these two or collaborating between these two cytokines, sputum eosinophils is probably a better measure. It takes into account both of these. And whereas the literature says 3%, many people have estimated if you even have 1%, we're not talking about absolute counts, but 1% eosinophils is abnormal and probably represents some pathology. IL-13 controls inducible nitric oxide synthase in the epithelium and produces NIOX. And greater than or equal to 25, although for ICS users, greater than or equal to 20 is probably a better estimate. And then finally, you have both total and specific IgE. It's a different category. It really doesn't measure inflammation. It really is one of the factors leading to inflammation, but we do include that in the GINA guideline, interestingly, as a type 2 biomarker. And basically the threshold is whether you have positive or negative. So eosinophil counts are the cornerstone of how we phenotype patients. Do most of you use exhaled nitric oxide when you see patients? It's about 30% of practices in the US actually have access to it. So we base most of these decisions on the blood eosinophil count and clinical indicators. And the things that we know reduce it are oral steroid use, even low doses in the past couple of weeks, and African-American descent or African descent. And both of those can lower it. And blood eosinophils change over time. It's a very dynamic process, particularly if you're a patient who typically sits between 150 and 300, and I'll show you some data in a moment, you can go either low or high, depending on what's going on in the external environment. Now, some recent data cast doubt on the absolute value, and it's actually, if you track people over time, it's sudden changes in eosinophil counts in the blood that are the best predictors of an exacerbation. So if somebody shoots from, let's say, 110 up to 210, they're not super eosinophilic, but at the same time, that's a sudden change and may presage an attack. So one of the bottom lines of this is we can't really go on the basis of a single blood eosinophil count. So if somebody comes in at 450, the chances are they are truly a consistent type 2 patient. If they come in at 120, you want to get multiple samples over time, particularly during an exacerbation. So Brad Schiff's published this, or about 4 other publications with similar data, taking patients from a Genentech omalizumab trial and just following the placebo-treated patients over a year, where the only influence that they're on is a steady dose of ICS plus LABA. And what they did was they separated it into, I think, what are really 3 of the key categories: less than 150 EOs, 150 to about 300, greater than 300. And they looked at greater than 60% of the time over a year of monthly sampling, greater than 70, greater than 80, greater than 90. And you can see that as you looking at greater than 60, people stay in the category roughly the same amount. But as you get to trying to define people who are really consistently in that category, as you get, for instance, to greater than 80, you can see that people in that middle category, 80% of the time, or 80% of the patients will not be in that category 80% of the time. So it's a funky statistic, but it gives you the idea that the most waffling is done by that middle group of eosinophilic patients. And in the other trials that have been done with other drugs and with other samples show very similar findings. So something that's really become, I think, in the vogue is this idea that not all patients are going to be eosinophilic and have an elevated nitric oxide. And some of that stems back to the work that came from John Fahey's lab, where they did single-cell RNA analysis and found that the correlation coefficient between people making IL-5 and IL-13 at the single-cell level is about 0.7. So that means sometimes one will be higher than the other. The majority of the time, both will track together, but there will be patients where there will be one of these biomarkers dominant. And Simon Couillard, who's publishing a lot on this the last couple of years, has broken it down into people on the left who are eosinophilic dominant, people that come in with EO counts of 600 and NO of maybe 25, 30, and people who are phenodominant, where they may come in with 80 to 100 and have sort of marginal blood eosinophilia. Then there are people who have both that track together. And you can see the kind of clinical characteristics that go with eosinophil dominant, those people that come in with nasal polyps, it's late onset disease. They don't have a lot of atopy. And these people are notoriously corticosteroid resistant. And if you compare this with the people that are more phenodominant, it's a younger patient, maybe the child who develops asthma, and you see these children with NOs of 80 or 90, and they don't even necessarily seem that sick, because IL-13 seems to have a very robust effect in these patients. And they are more corticosteroid responsive, but it's not to say that they will not have asthma for life. Much less nasal polyp disease, much more allergic rhinitis and atopic dermatitis. So what we're starting to do really is try to use the biomarkers we have to make a better estimate of what drug will work, so that we're going to get into that information now. So what is the unmet need in patients who have severe asthma? And I think, this is data that we hear many lectures. It's estimated about 10% of people are severe. In some series, much more than that. And about half of those people, about 5%, are considered poorly controlled. And we're going to look at some data about that reflects what are the effects of standard of care therapy. What contributes to this state of not being controllable with standard of care, using an inhaled steroid very adherently, or a LABA or a LAMA? Well, first of all, when they say they're adherent, we have to take that with a grain of salt. No matter what people say, about 40% of the time, people are actually adherent. And it's poor adherence to therapies that really put people into trouble. We should always be cognizant of that when we approach patients before launching into very, very tailored therapies that are by nature much more expensive. Comorbidities, things like nasal polyp disease, creates an element of corticosteroid resistance, along with gastroesophageal reflux disease, or the chronic burn of the lung through epithelial damage. People who use their drugs, and we see this all the time, but continue to have the cat that they inherited through marriage, and that cat who sleeps in the bed sort of wrapped around the head. And I understand that completely, because I had one of those cats wrapped around my head. And that can overcome the best of therapies just because the allergen load is huge. It died during the pandemic, but it was old. It was old. Chronic airway remodeling is something we have to be aware of. And this can occur after a year of asthma. We see children with one bad infection, they develop asthma, and their FEV1s down in the 70s or 80s, which is very low for a child. But particularly in older adults, starting in the, I wouldn't say older, but adults 50 to 60 years of age, where we no longer see reversibility. And these are in non-smokers. So we know that this is something to do with the asthma. Non-type 2 inflammation, where we've ruled out everything and they're in that small group where it's not a type 2 process. And we know these people are notoriously poorly responsive to both oral and topical corticosteroids. And then finally, type 2 inflammation, where people, it's the more robust usually, eosinophil counts greater than 600 or 700, often with nasal polyps. And to put all this in perspective, it leads to just lots of steroid use. About 10% of patients in the US are still corticosteroid dependent, although that's data from a few years ago. It may be getting better. And about 30 to 40% of patients every year need a burst of steroids to control an acute exacerbation. That statistic is much harder to control because even on biologics, people do break through with the right virus. And I want to come back to this issue of adherence. Overall adherence typically is less than 70%. 6 to 44% of patients fail to fill their initial prescription. That's how difficult this problem is. And when you look at ICS use, less than 50% of the time, it's the majority of patients. And adherence to LTRAs, if we talk about a very easy to use oral drug once daily, it's not particularly great either. And we're looking at 18 to 60% range of use. But this is a study that was published a few years back in the Blue Journal, Pulmonary Journal, that looked at people after discharge from the hospital. And 14 days later, the adherence rate was only 41% after being hospitalized for asthma. So this is the thing that we're up against, and it's not an easy task to deal with. What happens when you really maximize adherence? And this is Eric Bateman's study. Many of you are aware of it. It was called the Gaining Optimal Control of Asthma study back in 2003, when it was so-called the American Review of Respiratory Disease. And they did a reanalysis of that about 16 years later. And this is the data from the Annals of Allergy that looked at that. And what we're looking at with the blue outline, which is the lower of the graphs, and let me drop back a step and basically describe the study outline, which was people came in either off of inhaled steroids, on low to medium doses, or on very high doses. They were randomized basically to treatment, and they were either given a choice, not by their choice, but by the randomization code to get inhaled steroid alone or a combination of fluticasone plus salmeterol. They were then titrated upward every 3 months until they got good control of the asthma. So what we're looking at are fluticasone versus fluticasone plus the guanine beta agonist. The blue hatched area is very well controlled asthma. The upper area above that is partially controlled. And we can see as we go from inhaled steroid naive patients, even in that group, it's very difficult to really acquire well-controlled asthma. And as you go to people in the middle tier who came in on low to medium dose inhaled steroids, very similar. And as you get to people who come in on higher doses, very difficult to get well-controlled asthma. About 25% of people will be poorly controlled despite good compliance. And they monitored adherence very well in the study. So even in the best of worlds, in the best of adherence situations, you're still left with a significant portion of patients who will need something else. So what are the consequences if we can't control the disease? Well, certainly many studies have shown a higher future risk of exacerbation, that if you have 2 or 3 in the year today, you're going to have 2 or 3. That's why it's so important in biologic trials to identify people who have had exacerbations. If you don't have one this year, the chances of having one in the following year are about 20%. Poor health-related quality of life and daily burden of disease, oftentimes the main reason for treating with more advanced, sophisticated treatment. Loss of lung function over time. Every time you have an exacerbation, you ratchet down your lung function. So it's a stepwise thing, not in every patient. But when you look at population analyses, that group will lose lung function with every additional exacerbation, including mucus plugging, which can be very static over time. They've identified plugs that can last easily longer than 3 years in the exact same location. And then finally, what is it costing society? In the next 20 years, probably $1 trillion, and that's in 2022 dollars. So particularly with newer medications and hospitalizing people, where the cost of hospitalization is incredibly expensive now, lots of money to be spent. So when we look at some of the general considerations for using biologics, the FDA has come up with 3 categories. allergic asthma, the first one that was actually deemed a treatable cohort with omalizumab. Eosinophilic asthma came next, and then finally severe asthma without biomarkers. And that's because of the newest medication that's been developed that we'll touch on later, which works in both low and high type 2. Efficacy for all the medications we have, and everything we have now is a type 2 medication, is better with a prior history of exacerbations and the presence of nasal polyposis. Applies to every one of the drugs we use. Now, what is the importance of biomarker elevation when we're starting to ponder what drug we're going to use? Well, for blood eosinophils, it's related, this count is related to the efficacy of all currently available biologics. So no matter which drug you pick, they're going to do better on that drug if their eosinophil count is higher. For pheno, this doesn't apply to the anti-IL-5s. So if they're one of those people who are pheno-dominant and have a low eosinophil count, it does not predict the efficacy of anti-IL-5s, but it does predict the efficacy of things like omalizumab, dupilumab, and tezepelumab, all of which are much more broadly acting drugs. And then finally, does total IgE predict anything? Not even for omalizumab does it do so. So even if you come in with an Ig of 1,000, you're able to dose the patient adequately to eliminate all IgE, doesn't mean that they're going to do better than somebody with an IgE of 100. Its only utility is in identifying either ABPA or trying to figure out how much omalizumab you're going to dose the patient with. So I think it behooves us to always think about what are the things I've got to collect, both at the start of treatment and as I go through treatment. What should I really keep track of? And I think that right now we're not asked to do this by insurers, but certainly we will be, and it will be a day very soon in the future. The number of exacerbations they had at baseline, at least in the past year. What's their oral glucocorticoid use? Is it 3 months in the last year? Is it daily? And what's their dose been on average? Their lung function, including reversibility, using quantitative measures of asthma control and quality of life, trying to understand their use of inhaled beta agonist treatment, because that really helps more than any other factor describe the daily burden of disease. Type 2 biomarkers, both blood eosinophil count and pheno, and again, looking at those specific and total IgE if you're thinking that omalizumab may be the best drug for you. These are the drugs that are approved. So we've got omalizumab for allergic asthma targeting IgE, and we can see the comorbidities. It's now a growing list, and it's approved down to age 6. Mepolizumab and restylizumab, the two drugs that actually bind to IL-5 as their ligand. Mepolizumab got an approval in children for eosinophilic asthma, and you can see that comorbidities that typically occur in adults. And restylizumab, because they were never able to convert that IV formulation to a subcutaneous successfully, really never got traction as a drug that's commonly used. Benralizumab, very different from the anti-IL-5s in that it binds to the receptor and causes apoptosis down to age 12. And again, starting to acquire some comorbid conditions. And for both of the anti-IL-5 drugs and anti-IL-5 receptor, these are very rare comorbidities that we see in the population. Dupilumab, approved in children, binds the IL-4 receptor. It's been given the designation of anti-eosinophilic drug, interestingly, because the FDA didn't really recognize a type 2 controller. But we'll see in a moment that it applies to more than just eosinophilic patients and in a growing list of indications. I think I left one off, actually. And then finally, the newest drug approved, tezepelumab, because of the fact that it treats both eosinophilic and not eosinophilic patients, the FDA gave it the designation of a drug for severe asthma, not requiring biomarker documentation. And at this point, they're working on an indication for nasal polyps, but at this point in time, this anti-TSLP drug does not have any other comorbid indications. So let's take a step back again and think about how do the drugs really work? Because oftentimes we don't really process what are they doing and what are some of the less obvious consequences of their use. When we look at omalizumab, now around for over 20 years, we know that it reduces serum and cell-bound IgE. But what are the consequences of this? Well, certainly we look at it as a drug that stabilizes mast cells because you've removed IgE-dependent activation of those cells. And this leads to a reduction in cytokines and mediators with less asthma. But importantly, when you get those IgE molecules through use of omalizumab off of dendritic cells, you unleash that cell to be able to function optimally. And what that means is those dendritic cells, which are very important in dealing with viral infections primarily, that cell is now able to make gamma interferon the way it's supposed to, and that unleashes it to do an enhancement of viral killing. And this is why when we look at the inner city asthma study with children, that there was a reduction in viral-induced exacerbations in children treated with omalizumab. And then finally, something we almost never think about from Steve Durham's lab, a reduction in IgE-facilitated antigen presentation, to some extent by dendritic cells, but to a large extent by B cells, which are very good antigen-presenting cells using IgE as a presenter in patients who have established atopy. This keeps the fire burning, and through the omalizumab treatment, you get long-term reductions in IgE. After the initial increase that we're all used to seeing, over a period of years, it actually comes down and then goes below baseline levels. Now, we can't say it's disease modifying, and I'll show you data about that, about remission, but it does modify some of these long-term processes. What we don't know is that those levels pop back up through allergen exposure. Once you make too much TSLP, and you're born with that gene, how do you stop that? And that's what makes remission a challenge. But with omalizumab, this is the data from Nick Hanania's post hoc analysis showing that if you're looking at the left, pheno above and below 19.5, eosinophils above and below 260, and periostin, ignore that final column since we don't use periostin. Didn't pan out to be a very consistent biomarker. But you can see as people have more of the type 2 biomarkers, pheno and eosinophils, omalizumab does much better. And in fact, when they don't have elevation of those biomarkers, the drug doesn't do much at all. Now, interestingly, there was a Tom Casale paper showing that it didn't matter if they were low or high EOs. That data was based on non-placebo controlled data points from a group of patients, sort of real life data. So I'm not going to show you that data. I don't think that's as reliable. But I think given this data, this is behaving like most of the other type 2 medications other than tezepelumab. So, we did studies in 1999 using mepolizumab, using the FDA's approach. We gave it to a bunch of patients, irrespective of their eosinophil count. And lo and behold, what happened? Nothing. It didn't work. And then the nail in the coffin of the drug at the time was they used it in an allergen challenge model. It did block eosinophil influx into the lung, but it did nothing to block the early and late phase response or subsequent non-specific hyperresponsiveness. So the drug fell asleep, it was on the shelf, until groups in Canada started thinking, well, if it's an anti-eosinophilic drug, why not use it in patients who have very high eosinophil counts? And around 2009, Dr. Haldar did the studies, and they published in the New England Journal showing it was a brilliant medication for people with hypereosinophilia. So the drugs that bind to IL-5 reduce the activation of eosinophils, they reduce survival, they reduce chemotaxis out of the bone marrow to the lung, probably have an effect on basophil priming, which may be important during exacerbations. And with the drugs that bind IL-5, you don't get 100% reduction in EOS, about 80%. And if you compare this with benralizumab, which binds to the IL-5 receptor, causes apoptosis of the eosinophil, consistently 100% reduction in blood EOS. Does that matter? It doesn't appear to from the clinical trials, that they both have very similar performance. In fact, some of the trials favor mepolizumab. So you don't really need to get rid of all of these. You just need to get them down to a reasonable level. But when you talk about eosinophilia, then devil is in the details. What we're looking at here is data from the Mensa and Musca trials published by GSK. And what they've done in the upper is broken down the eosinophil counts into categories, less than 150, 150 to 300, 300 to 500, and greater than 500. I'd like that stratification because the 300 to 500 do behave differently from greater than 500. It's that greater than 500 group that frequently has nasal polyps and are corticosteroid resistant. But what I'm most interested in is that 150 to 300 group, where they did not get a clinically significant reduction in exacerbation. In the less than 150 group, they did, and this may be by virtue of oral corticosteroid use. So you may be getting patients who are, where you're getting a misread on their real phenotype. But this shows up in the European label that between 150 and 300, mepolizumab did not do very much. It did nothing for pulmonary function. And I think, therefore, when people are down to 150, you have much better choices than using an IL-5 or an IL-5 receptor inhibitor. Now, dupilumab is truly pleiotropic. It's doing a lot in the asthmatic lung. It blocks the effect of IL-13 on the epithelium, and therefore you see a reduction in FeNO. Now, that's more of a laboratory phenomenon. The question is, does that really make a difference in terms of FeNO acting on the lung? Probably not too much. You get an inhibition of eotaxin 3 and ICAM1. The blockade of these eosinophils getting into lung tissue is what probably is responsible for that transient increase in blood eos that we see in all patients who end up getting dupilumab, which does come down over time in the vast majority of patients. Sometimes it continues to rise, and that may be an issue in a small subgroup. There's a possible reduction of the eosinophils getting into the lung. There was a little bit of data published in an abstract in a small number of patients showing that there might be a reduction, but this has not been something that Regeneron and Sanofi have been able to demonstrate convincingly that the drug actually prevents the ingress of these cells. But it doesn't really need to because it's doing a lot of other things. Reducing the IL-13 effects on bronchial smooth muscle, we don't know exactly how this works, how IL-13 even increases smooth muscle responsiveness, probably through calcium influx, but you get an enhanced response to beta agonists and an increase in pulmonary function when you treat with dupilumab. Something that's important to allergists is the effect of IL-13 causing IgM to IgE class switching on B cells, and that is blocked, and therefore you do see over time in dupilumab a long-term reduction, quite significant, in both total and specific IgE. And then finally, something we don't think about, and this is not an IL-13 effect, it's an IL-4 effect, which is generating allergen-specific memory Th2 cells over time. And in this regard, with years and years of use, we may be seeing the possibility of disease modification, but we have not been able to show it yet. But we do see in the trials after 2 years of use, there's a reduction in blood eosinophils that actually goes below the baseline. Now, this is the data from Mario Castro's paper a few years back, looking at individual biomarkers. And what this really tells us is, as you look at whether it's eosinophils on the top or FeNO on the bottom, as you go from low levels to higher levels, you get this nice dose response curve in the efficacy of blocking exacerbations. But when you get to that lowest tier, which is less than 150 or less than 25 of FeNO, you really don't get an effect. Okay, so this is really a Th2 dependent drug. The question then becomes, what if you block one biomarker, let's say IL-5 and hence eosinophils, versus the other, IL-13 and hence FeNO? And this is supplement data from that same paper. Looking at the effect on the left, you're looking at high FeNO with low eosinophils, less than 150. On the right, you're looking at low FeNO and high eosinophils greater than 150. And you can see that you do get reductions. Some of these are not necessarily statistically significant because of the smaller sample size, but the effect still seems to be operative. So one of the questions would be, would this be a suitable drug in somebody with a FeNO of 60 and an eosinophil count of 180? It might be, but there might also be better choices. So atezolizumab, the most recently approved drug, one of the big things it does is reduce, you know that TSLP increases OX40 ligand on dendritic cells. And that may not sound like an important event, but it is what allows that dendritic cell to present antigen much more effectively in the presence of IL-4 to a naive T cell. And it's that pairing between multiple molecules that bind the two cells together that lets that allergen-specific T cell take place. And by blocking TSLP, little movement of the slide there, you get a reduction in the generation and activation of allergen-specific Th2 cells. At the same time, you're getting a reduction in innate immune cells, like ILC2, mast cells, eosinophils, has an effect on virtually all the cells involved in the inflammatory cascade, which then leads to a reduction in the principal Th2 cytokines, IL-4, 5, and 13. Both of these two things together give rise to a reduction in blood and tissue eosinophils, FeNO, and total IgE. And at the very bottom, we should never forget that TSLP released from the epithelium will activate smooth muscle. The smooth muscle now becomes a secondary generator of TSLP, which is very interesting. And you end up then with a positive feedback loop. the more smooth muscle grows and the more active it becomes, not necessarily contracted, but active and waiting to contract, that you get by blocking it, you get a reduction in bronchial hyperresponsiveness and an improvement in lung function. This is the only drug, I think, that really had the foresight to do a lot of this basic mechanistic work before the drug was even actually FDA approved. So there's lots of studies now looking at this issue of bronchial hyperresponsiveness with tezepelumab, whether it be methacholine, which is important, allergen, which is very important, or mannitol, which is something we don't use very much, but very interestingly represents how the mast cell functions in the asthmatic lung. I'm going to show you this data because it's really interesting. I showed you to Lynn last night, but we're looking in the upper left, we're looking at the eosinophil counts below that pheno, and then in the upper right corner, we're looking at total IgE. So what we learned from this is when you use the human knockout of TSLP, stop TSLP abruptly, you get sudden reductions in blood eosinophil counts. And why would that be? Because in real time, you're able to stop the activation of these cells. And by stopping the activation of Th2 and ILC2s, which are both important in this, you're getting a sudden drop-off in interleukin 5, along with the other cytokines. What kind of a drop-off do you get with this drug? It's been published on, it's about 50%. So the drop in IL-5 corresponds with the 50% drop in eosinophils, which stays suppressed. Pheno, a very similar phenomenon. A sudden drop in activity, which then stays suppressed. IgE is different. It's a slow meandering drop. And a study we recently published looking at a cat exposure model after a year of use of tezepelumab, that IgE continues to fall off over the following year. So we don't think it's just an effect on IL-4, but probably an effect actually on B cells that are capable of producing IgE. And those effects may be much longer lived. And no matter which biomarker you look at, whether it's high or low, no matter what category, the effect of tezepelumab, whether it's low T2, high T2, low EOs, high EOs, low pheno, high pheno, you're getting statistically significant reductions in exacerbations. So when we put all of this together, I'll let you kind of peruse that table for a second. The drug is listed to the number of randomized clinical trials, and we're looking at the reduction in exacerbations. And what we see typically, including omalizumab, are changes in the mid-40s. With the anti-IL-5s, it goes up into the 50s. With dupilumab, not using an eosinophil cutoff of any level, just taking all comers, you get an increase in exacerbation reduction. And the same for tezepelumab, 54 to 71% range in reduction of exacerbations. And this shows you the biomarkers that we've already reviewed. So we've got a lot of good drugs available, and the question is when to pick which.
I had to fail on reduction of chronic oral steroids.
That's almost a lecture unto itself. In the trial that was done using the drug, they got whatever patients they could. We were one of the participating sites. Typically, when these studies have been done with most of the other drugs, a certain percentage of the patients will have high EO counts, even on oral steroids. And that might be 70 or 80% of the patients. In tezepelumab, a very small number of patients entering actually had high eosinophil counts. When many of those patients ended on placebo, they ended up having low type 2 asthma. They ended up being in that small group where they were able to taper their steroid dose completely in patients getting placebo, because they were in a group of asthmatics who never really needed the steroids. So that study is now being redone, and I assume it'll be positive. Excuse me. The old approach to trying to get remission in patients is take an inhaled steroid, increase the dose. If that doesn't work, go ahead and add a beta agonist, add a LAMA, maybe add montelukast or Zyflo if you can get it. Maybe even add theophylline, maybe add azithromycin, without really thinking about what is the catchment area for this particular patient. Are they hypereosinophilic, or can we just push conventional therapy? But the new approach really is tailored. It really phenotypes the patient early on in every possible way, both by biomarkers, by natural history of where they've come from, and all of the factors that might lead to the success of a more specific drug. when we talk about remission, what we're really talking about is trying to get people to the point where they don't know they have asthma. And some attempts have been done with this. I think the best attempt is a 2024 paper that was published in the Blue Journal. And what we're looking at is, depending on the number of criteria you use to call it a remission, this will determine your success. So if all you're asking for is get rid of exacerbations and get rid of oral steroids, excuse me, about 50% of patients, irrespective of which biologic they got, will fall into that category. This is on treatment. This is with at least 6 months of treatment. But as you add requirements into the definition of remission, now you're going with the first two, but you also want the daily burden of disease gone. You want it to be very well controlled. No beta agonist use, no symptoms. You're down to about 33%. If you then throw in FEV1, which I think is probably unfair to trying to get these drugs to work, because once they're remodeled, you're down to 25%. And then if you throw in all of the above, plus both FEV1 and daily symptom control, you're down to about 20%. I think probably the blue line is what we're shooting for, and that's only about a third of patients. And if we look at this on a drug-by-drug basis, anti-IG, omalizumab on the left, and IL-5 drugs in the middle, and then dupilumab on the right, we can see that there is some difference in the ability to render the patient exacerbation-free and oral steroid-free. And it looks like dupilumab is the most effective in this regard. But as you then add layers upon layer to see what else can we get out of this definition of remission, it gets less and less probable. What's important to keep in mind is that there is no data showing remission off drug. So I think just trying to get really good control where they're on these drugs is really something that we have not yet completely met. So I think, can we cure the disease? There are some opportunities I think we have, but right now they're not being considered. So when you compare these drugs in general, first start off with, there are no head-to-head double-blind studies showing how these drugs differ, and we're not going to see them. Because if you don't power it enough, then you're really powering it for non-inferiority. So whoever sponsors it is going to be able to say that they're the same as the competitor. I don't perceive that as an outcome. But there are indirect comparisons of randomized clinical trials, and I think that's where we should really be looking at. But they can be difficult, because as we saw with the steroid-sparing trial of tezepelumab, you've got a different patient pool waiting for you, looking at 2013 comparing with 2023. And when you start to look at multiple comparisons, you start to see a lot of statistical issues. The problem with real-life studies, that's even more, I think, problematic, because the way people actually use these drugs in clinical practice, some of the people don't meet biomarker criteria. Some of them really were not adherent to their inhaled steroids. Lots of issues, which really, I think, making comparisons very, very difficult. But what we can say is, from the existing well-done systematic meta-analyses that did not include tezepelumab, it was dupilumab, anti-IL-5s, and omalizumab, it appears that dupilumab has a greater effect than the others on exacerbations and lung function. And I showed you some of that data a moment ago. But differences in subjective parameters like quality of life, ACT scores, ACQ scores, have not really been demonstrated between the drugs. So there are things to distinguish these, but probably our clinical experience may be the largest of those. In one claims-based study of biologics in asthma, it was over 5,500 patients, and you can see that they included all the different drugs. One of the things they found out was that people who had less than 2 exacerbations in the year before entering this trial had marginal reductions in exacerbations in the year to come on biologics compared with baseline, because you're not starting off with a strong signal. But in people who had greater than 2, this is where you really see the drug have efficacy. And I think we always have to keep this in mind, that why did they exacerbate? Was it a virus or bacteria versus something else? But when you look again in this particular analysis, the reduction relative to the other drugs, which dupilumab was higher. And now we're getting enough data with tezepelumab to be able to insert that into these models. Safety, I think in general, we looked at these drugs as really being amongst the safest for biologics in any disease state. Omalizumab, rare systemic reactions, no real increase in chronic end organ damage, such as cardiovascular. That was a consideration in the beginning. Mepolizumab and benralizumab, they get rid of eosinophils. Doesn't seem to matter too much, not at least in the short term. One of the questions is, since these cells, these eosinophils, are charged with the responsibility of cleaning smooth muscle and going in, getting free radicals, cleaning up the muscle, might we see long-term muscle disease 10, 15 years down the line of consistent use? This is something we'll just have to be vigilant about. With dupilumab, we are seeing conjunctivitis. Originally, we saw it in atopic dermatitis. We are now seeing it in asthmatics as well. There are patients with persistent eosinophilia, and there have been reports now of EGPA with this drug. Small numbers, but they are emerging on a steady basis. Very rarely psoriatic skin disease. I had a patient with this, and we think what's going on in these patients is that as you completely block the IL-4/13 axis, that we think theoretically it's possible that you're shifting people into a Th1 axis, similar to what we do on an allergen-specific basis with immunotherapy. We know we're doing it. We want to do that when we give allergy shots. But here, it's such a complete blockade that you run that possibility, and you have to be aware of that. With tezepelumab, we were initially very concerned that you're upstream in the cascade. Question is, which cascade? It's the cascade that governs type 2 immunity, mainly responsible for antiparasitic immunity, maybe to some extent antifungal immunity. In all the studies we've looked at, there's no signal of any increase in viral or bacterial infections. So far, this has played out to be a very safe drug. There are still some concerns because it's relatively new, but so far those haven't been realized. Other biologics, past and future, and this is sort of like the greatest hits list. Many of you probably participated in these trials. Inhaled biologic therapies. I feel like Phil Maher going through, or David Letterman. I'm not done yet. Anti-IgE was tried in vain, anti-TSLP. Both of these approaches were not successful. It appeared you had to have a systemic component because many of the cells, immune cells and mediators, were being systemically derived. So just to be present in the target organ wasn't enough. Anti-IL-17A, brodalumab, an Amgen drug, was tried, and anti-IL-33, sponsored by Regeneron. The anti-IL-17A had no effect, even in low type 2 patients, sort of getting rid of the idea that IL-17 is an active mediator in non-type 2 asthma. With the anti-IL-33, there were effects, but in combination with dupilumab, there did not appear to be any advantage. So for the time being, that drug will not see the light of day in asthma, probably will in COPD, where IL-33 may play a more important role. Ongoing trials to look for anti-cytokine monoclonals with longer durations of action, up to 6 months, 2 shots a year. Anti-cytokine oligonucleotides, they're given by the injection route, again, with up to 6-month duration of actions and presumably no toxicity. Combination biologics, I think this is a very hot area being worked on by many pharmaceutical companies, combining primarily anti-IL-13 or 413 plus anti-TSLP. So the question is combining an alarmin, anti-alarmin plus a downstream cytokine blocker. And then finally, some other targets for inhibition, OX40 on dendritic cells or on T cells and OX40 ligand on dendritic cells. Will these make a substantial difference? I'm not sure they will. I think we're in a really great situation. When we look at all of the things we have available, our understanding of the disease, doing earlier intervention, not necessarily with biologics, just with good care, particularly immunotherapy, which we often don't talk about, I think will make a world of difference. And when we look at data in the United States, certainly asthma deaths are extraordinarily rare. Other parts of the world, not so much. South Africa, when I last checked, still has about a 1% death rate, 1% death in children with asthma. So it's really astronomical. So we've got to get some of this knowledge and access to some of this, out of the US. Now, it's interesting. Part 3 of my talk was individualized approaches and case studies. I think it's now 8 o'clock. We'll probably have to skip that unless you want me to do one case. Who says one case? Vote.
Go ahead.
Okay, let's do it. Case one, a man, 49, recurring sinus disease, developing nasal polyps in his early 40s, loss of smell, loss of taste. After that started, when he would get an acute sinus infection, would start wheezing, what we typically see, kind of a bronchitis situation. But then around age 46, took some Advil, actually, call it aspirin sensitivity, and had a sudden severe attack, landing him in the emergency room. And the polyps were so big, by age 47, he had them removed. Most of the time, despite taking high-dose ICS and LABA/LAMA, montelukast, washing his nose with budesonide, still having asthma, and still having exacerbations requiring steroids. He's got polyps on exam, very low FEV1, which only reverses partially. And skin tests are completely negative, not surprising. Bloody eosinophils, he's in that greater than 500 category that we talked about, 520, and at the same time has a very high pheno, kind of giving the idea that not only is IL-5 at work here, but IL-13 seems to be very robust. What's his diagnosis? Dr. Tillis, I'm going to call on you.
I put him on 2 weeks of prednisone. Sounds like asthma that's in the non-type 2.
Well, he's eosinophilic, so non-allergic. Not allergic. Everybody agree?
We call intrinsic asthma.
Intrinsic asthma. It's not a bad name, actually. It's not
A lot of these old-fashioned scenarios are being validated by this.
right, extrinsic and intrinsic. So aspirin ERD with severe non-allergic eosinophilic asthma. What are the biomarkers that we're relying on here? I would say both, right?
Yeah, we've got.
Yeah, he's got big ones for both pheno and blood eosinophils. What's the big comorbidity in these patients?
Sinusitis and polyps.
That's right. Would you call this significant FEV1 impairment?
Yeah.
It is severe. Now, those were all the gimmies. Those are the easy ones. What would you treat him with? Any other choices? Any anti-IL-5 lovers? Tezepelumab? Which drugs are approved for nasal polyps? So dupilumab, mepolizumab, and omalizumab. Now, he's not allergic, so I wouldn't put him on omalizumab, even though the omalizumab data showed equal efficacy in both allergic and non-allergic polyp patients, interestingly. But I wouldn't expect the asthma to necessarily respond with a complete absence of atopy. So I agree with you. Dupilumab would be my first choice, mepolizumab, and if the only thing available was omalizumab, then I would use that. Why not tezepelumab, which seems like a perfect drug for this? Doesn't have an FDA indication yet, although post-hoc analysis from the phase 3 studies show that there's a very strong signal in blocking nasal polyp symptoms. I think I'm going to stop there because the next two cases are very different and I think they're interesting, but why don't we stop there? And are there any questions?
But Jonathan, why did some young children, we're talking about disease modification or possibly cure, why do a certain percentage of young kids outgrow asthma? What caused it and what changed?
Well, we attribute some of it to hormonal changes. Whether that's true or not, we're not sure. It's usually people with mild disease. The kids that have airway remodeling and lower FEV1 and frequent exacerbations are typically not the ones. Occasionally, yes, but for the most part, no. They will continue to be problematic during adolescence and very likely into adulthood. Not always, but very often. So, the question is, what is the timeline that allows this to happen? I mean, I would put my money on, there are healing processes at play here. If they haven't had significant remodeling, that are able to occur in these children, through what mechanism, I'm not sure. Hormones may play a role, but some of the other cytokines that we know exist, the question is, which way does TSLP work in much younger children maybe one of the issues that it may be promoting some kind of, beneficial, process, but we're not sure of that. Any other questions?
One other question, and people in the audience don't know that the early stage developer at Genentech for omalizumab, credits Dr. Corren working out the dosing table for omalizumab back in the day. I don't know if you remember that, but
That was so long ago, I can't even remember.
yeah, but what I was going to say is back in the day, the unmet need was a lot different like 30 years ago. Omalizumab came on the heels of long-acting beta agonists and high-potency steroid. And you did a great job of sort of defining the current unmet need. How does that compare? If we're talking about common good and the cost of treatment, which is now sort of achieved generic status, but at least with the inhaled stuff, with a lot of it. Where does that leave us now and that 10 years from now, if there's $1 trillion being spent? Do you think that 5% huge unmet need could get down to 1%? It's a impossible question to know.
I mean, I think some of it's going to depend on, a lot of this asthma that we're seeing, the worst of it is in children living near, generators of pollution, and they're really, yeah, exactly. Freeways, industrial plants, things that are generating a lot of ozone, things that are generating, PM 2.5 particles that are getting deep down into their lungs, causing changes in their disease that, how chronic and permanent will that be? Could be very permanent. So, some of this will depend on policy. I think some of it will depend on early recognition of allergy. Going back to the PAT studies that were done in Europe using early immunotherapy, that we know there are these allergic patients that kind of are meandering along. They have rhinitis, eczema, they get asthma. A chunk of those will develop much more severe disease in their 20s and 30s. Why aren't we using immunotherapy, Tedesmite or what have you, in all of these atopic children where we know they have a 50% chance? And immunotherapy is cheap. It's cheap because the insurance companies don't pay for it, so it makes it cheap. but we're able to do it. We're still able to give it, and it's effective. And that data from Europe's never been repeated in the US. There's some data with sublingual, whether it's sublingual or SCIT. I'm a huge advocate of, as a public health measure, getting allergic kids into a position where we cure the disease rather than throwing them a nasal steroid as they're developing cough with exercise, knowing that those drugs will not be disease modifying. Of all the things I've talked about, the only thing that's disease modifying is specific allergen immunotherapy. And I think we should be combining that with some of these drugs, and like we did in the cat study, which was really gave a very nice result.
That's a very good point. This is the backbone of our profession. Have anybody followed things like, the mechanisms we think by which immunotherapy works is IgG4 and modifying mast cell degranulation. What about its effect on cytokines or eosinophil numbers or phenos? Anybody studied longitudinally some of the same biomarkers that you went through in this talk?
There's data showing that it does modify those things. If you look at the data from ALK, sublingual Desmite gave data. It was a milder group of patients, mild to moderate instead of severe. The reduction in exacerbation for that group was about 50%.
And there's data that actually prevents asthma too.
That's the PAT data. Yeah, the PAT is, if you're not familiar with it, large data set. Yeah, where they took kids either who had occasional asthma or no asthma, put them on not only mite therapy but pollen immunotherapy, and saw a 50% reduction in developing persistent asthma. One of the indicators that they might be most benefited would be a methacholine challenge. That's kind of hard to chop, but there is data, at least in adults, saying that in people who develop asthma, before they develop asthma, their methacholine reactivity is positive. Then over the next 5 years, they develop asthma. Very small amounts of data. Yes.
I was curious if you had any thoughts on why it is that for some of these patients on biologics that had objective improvements, like reduction in exacerbations and less oral corticosteroid use, why it is that their quality of life remained unchanged, why they're reporting that?
Is that from your own experience?
So, yeah, I think there was a slide that was saying that the quality of life measurements like ACTs.
Or comparing drugs? So universally, all these drugs do improve asthma control questionnaires and quality of life better than placebo. When you compare them, it's really hard to sort them out from one another. But it's an interesting point you bring up. When you look at placebo in those studies, looking at subjective measures, they're not that different from active drug. So in something I didn't mention, the best drug that we have found for reducing exacerbations is being in a clinical trial and getting either placebo or active drug, because in the tezepelumab, they went from 2.5 in the placebo group on average down to 1. So that's, it's like a 60% reduction in exacerbations.
Adherence.
That was adherence. Adherence and seeing a nice doctor like yourself or Dr.
Or
Tillis.
Frank Atkinson with the multiple, immunotherapy trial. 5 years ago, where it didn't show an improvement. It's because they were in clinic.
We can see why we invited Jonathan Corren to town. Thank you
Thank you, Len.
for struggling.
She saved the day.
We've been sharing the slides from his Zoom connection, so he's moving his slides as you were presenting.
Oh, thank you.